Hello, everyone, and welcome to our next Unfiltered Productions podcast. And we have a special guest today. Very excited. You have to begin well to end well. That's something that we looked at in K and talked about for a really long time about what happens with that patient when you first hear about them, when you first get a sniff of that patient possibly being a referral to your agency. And I want to introduce, obviously, you know who Cindy Kraft is. I'm pointing to my bottom square on the Hollywood squares. You might be the center square, Cindy. I think that's what you are, actually. The center square is Cindy Kraft today, the other owner of K&K Healthcare Solutions. I'm Sherry Teague, and our special guest is Lori Owens. And Lori, tell us a little bit about your company. We're so excited to introduce you to our subscribers.
Yeah, thanks so much, Sherry. I'm really excited to be on your podcast today. But I'm Lori Owens, and I am the owner of Healthcare Office Solutions. I initially started my business back in 2012 as a consultant, and recently restarted back in May. And my partner is Tina Badham. She's my clinical operations officer who's not on this podcast today, but we offer consultative services to our clients with home health, hospice, and private duty, really honing in on operations, understanding the basics, the fundamentals of what it takes to get paid, what it takes to meet compliance, all of those little elements in our day-to-day practices that either make or break us as an industry and whether or not we're profitable. Be here for the next round of changes.
And home health has changed drastically in the last 3 decades. I mean, we went from being a fee-for-service setting all the way to good God, proposed rule, the
PPS.
Prospective payment system.
Thank you. Wow. Episodic payment, and that episodic payments has changed significantly, with the most recent significant impact being PDGM in 2020. What else happened in 2020? Anyway, PDGM happening in 2020, and now moving into the penalty phases of value-based purchasing. So why the basics? Tell us a little bit about what you're seeing out there as far as the basics, Lori.
Yeah. So, we've had some past conversations, Sherry, and what we see really across the board on regardless of the size of the agency, your small mom and pop all the way to the big guys, is really a loss of the fundamentals of home health. And, you hit the nail on the head when you mentioned PDGM. And I remember talking to clients back before 2020 and said, hey, make sure you've got an appropriate focus of care. Don't just plot I-10 because that's going to, allow your intake people to push it on through. Nothing has changed. We still have to have a valid order from a physician. We still have to have a physician that's willing to sign the orders. We still have to meet all of the expectations. Just because you can use I-10 and get through and I'll quote this, get it to the next stage. We still need to do all of our due diligence up front. We have to do that right. As you mentioned, if you start right, you will end right.
And you'll save yourself.
Stephen Covey says, start with the end in mind.
Right. And it'll save you a ton of money on the end, chasing this paperwork and sending out office people and spending valuable clerical time chasing physicians. And listen, we're going to start with physicians don't want to sign anything. They want to sign things less than they want to read them. And so we run into that. And that's a legitimate concern. So I want to start with the basics. You get a call, Mrs. Jones needs home health. What do you think that next step should be?
So for me personally, I ask for everything to be sent over to me. I want the demographics. I want to be able to validate my insurance. I want to make sure I've got an appropriate diagnosis for home care. And I want to make sure that I reach out to that patient. We just got a call from your physician's office and they've asked us to come out and schedule you for nursing or physical therapy or whatever the case may be. And make sure that you make that contact, that they know what's coming down the pike, and establishing that relationship with them. Because if you don't have a relationship with the patient and they don't know who to call when somebody doesn't show up or somebody else gets called in as well, you're gonna lose that potential referral.
And it's also consistent with the patient's rights and responsibilities,
Yeah.
right? You have to have their buy-in to everything that you would propose to them. Cindy, I wonder if you could talk about, because you and I are old in the tooth when it comes to home health, and you as a PT, as a gatekeeper, you often were the first one going out into a home. Excuse my Sherwood Forest, this is unfiltered. So what I want you to tell me about is in the olden days, back before PPS, back before what was the typical referral that you would get as an admitting clinician?
Well, you make it sound like it was a horse and buggy situation. It wasn't that long ago. But the typical referral was a name and an address. And typically, one of those two things was probably wrong. We get wrong phone numbers, wrong addresses, and try the best you hope for is at least it was the right person in the right residence. And it was pretty much you need to get out there and you'll just kind of figure it out. You'll talk to the patient, you'll talk to the daughter, you'll find the information you need. We'll get it to you later. And, being new to home health at the time, we kind of thought that was normal. That's just how you did it. And then as time has passed and we've seen rules really force people's hands about what needs to be there, what are those expectations, what is required in terms of the face-to-face requirement and those kinds of things all evolved from, was that really the best idea? Some people still reminisce about how much easier that was. I would argue in hindsight, that might have been easier on the back office for intake. It was not easier on me as the clinician because how am I supposed to figure out where to start with this patient or what to do if I don't have, the basics of the physician diagnoses? Why did you refer him to home care? I might find something different when I do my assessment, but at least I have an idea of what precipitated this referral because realistically, trying to get the majority of that information from the patient, too much of it is unreliable. I mean, I had a very close family member and I sat there through their admission to home health and could hear all kinds of things that I knew were not true. And there was no dementia, there was no maliciousness. It was just off the cuff. No, that's not a problem. No, that's not a problem either. I've been, before this, I could drive, I was shopping, I was doing all these things, and I'm sitting there going, oh my gosh, what does a clinician do when they don't get the right info? And I think what you see at times is clinicians get frustrated with intake about why can't you get this information? And so I think it's a bigger issue. I think when we look at the reason for a process, I think sometimes we look at it as how we expedite to billing, but I think there's a huge clinical component to this that says we cannot be sending people out without at least baseline information to better understand the complexity of this patient and make sure we develop the right care plan.
And it's super important that we understand in the agency whose responsibility is that. And I say that because ultimately, I just posted the other day that ultimately it's the clinician's responsibility. But none of us as agency owners are going to be sending our clinicians out to get this information from the doctor's office. All of us send someone out as a representative into the community. And Lori, talk a little bit about what inadequacies you're seeing from the expectation of what is truly a referral from your marketing folks, from your patient care liaisons, we used to call them, whatever you're calling those folks that are representing you.
No, I'm seeing agencies with referrals that it's a discharge summary from the PT while the patient was in the facility and some demographic page from the SNF. The patient's going home on Monday and we don't have a face-to-face. We don't have a true discharge summary. We have basics, as you mentioned, Cindy, like diagnosis information, but it's not necessarily what's pertinent for the home health referral, or even having a valid referral for home care. Nothing in there says discharge to home health services.
Yeah, it's
The
almost
OTST.
that people are picking up little trinkets and saying, not even looking at what they are, what's in the box, and bringing it back to the agency and saying, look what I found. I
Yeah.
found a referral. And agencies, unfortunately, have gotten into the habit of wanting referrals so much that they say, oh, that's good enough. Go get me some more trinkets. No, no, I cannot counsel everybody on this call or on this podcast enough. You need to have an expectation, and going back to basics. What are the responsibilities of your patient care liaisons? What is an actual referral? What do you consider an actionable referral? How do they tie their part of this process up into a nice little bow and hand it off to your office staff? Because I can just tell you, and please disagree with me if I'm wrong, you're costing yourself a lot of clerical money if they're just bringing a name and an address to your inner office staff. Typically, that first person in the office is not going to be clinical, so they're not going to be able to discern what is good and what is not a good diagnosis. They're going to do their part of the job and then push it on to whoever's going to do the review. But then you're already how many man hours into this process without having a legitimate referral. So I think that I've been on this soapbox for a while, Cindy. So talk to me about what you think that what is the minimum that the referral representative should bring to an agency?
Well, I guess I want to pivot this a little bit, Lori, because what you do is you really get in the weeds with agencies
Yeah.
and help them figure this out individually. Something that I've done in the past. I've moved on. And I have great respect because many times what I see on the other end, whether it is a documentation audit, whether it is trying to do, being brought in to do education to fix something, looking at outsourced coding in Oasis, I think we're seeing a lot of the end result. We're seeing a lot of that the end is not right. There are things that are missing. And very often I see agencies lay that responsibility directly on the clinician. That if the clinician was just educated better, if they paid more attention, if they weren't being difficult, then everything else would be fixed. So, as someone who spends time in the weeds, if I'm saying, okay, I hear what Sherry's saying, I don't know if my intake thing is working ideally, where would you suggest I start as an agency to look at it and say, I think it's okay. Maybe I've just gotten used to it having its bumps and problems. Where would you tell me to start looking or start peeling that onion to determine if I need to change anything or validate if I'm in a pretty good spot?
Wow. Um, so from my perspective, when I come into an agency, it's one of two ways. I either start at their AR and work my way backwards to find all the pieces that did not fall into place. Um, or I start at the very beginning with the referral. What happened? How did it come to you? What did your intake department do with that? What data is entered into your referral, into the EMR? So what is available to me as a clinician when I go into the home? Do I have appropriate attachments there that I can see and that are clearly marked, the discharge summary or my home health orders? Or is it an 80-page H&P that I've got to hunt and peck through? And some pages are this way and some are this way. And I've got a device about this size, trying to discern where is my order for home health or what am I here for? And honestly, like I hear a lot too from clinicians in the field that say intake has failed me. And they put it back on intake because they don't really know the whole
Right.
process, that it starts with the, referral with the liaison. But intake is our gatekeeper, right? They are the ones that should be able to say back to the liaison, hey, thanks for the demographics, but I need X, Y, and Z. And you don't have to be a clinical person to be able to say that. And, I've been in this industry for a very long time, as you both have. And I see really a lot of oh, well, my intake department's not clinical, so they can't make that determination. Uh, let's be real honest. Intake wasn't clinical people 20 years ago.
Nope.
And somehow, we were getting that information to our clinicians. I think that as an industry, we've changed expectations on people in-house, and maybe those things don't always align with what our roles really are. We've got clinical managers that are worried about, did it meet TEOC, or, where's my face-to-face, or other pieces, and they're chasing behind the clinicians because, like as you mentioned, we've put all this onus on the clinicians.
Mhm.
But if we just go back to the basics and the fundamentals, does it really make sense that those things lie on those clinicians' shoulders? Or should we be taking care of it up front? And are the people that we have up front capable of doing accurate data entry, putting in our allergies, putting in our appropriate contacts, attaching those documents, recognizing, okay, I have a face-to-face, or, is this signed by the physician? Do I have an actual order for home health? I just, I don't know. Personally, I feel like we've kind of dumbed it down
Mhm.
and made intake just a data entry function and taken any of the accountability and the decision making out of the role.
Do you think part of it, Lori, is when agencies look at shrinking dollars every year? And thankfully, we got the final rule and dodged the big bullet. It's still a
Yes.
hit, but it's not what they were threatening us with.
Yes, thank goodness.
That when you're looking at cost savings, that it can seem very easy to cut the back office because you need the clinicians to go out and do the care. And you're right. I see a lot of clinical managers that are also doing intake function, that are also trying to do QA function, that are also trying to supervise the staff, that are also trying to be in meetings to work on improving outcomes and star ratings. And I think that's not just in the small to mediums, where sometimes it's also the owner who's wearing 10 other hats.
Yes.
But it's also in the larger ones where we don't really need this one. We'll just roll this into somebody else's job. So I think that what we fail to realize then is you tend to now be consuming time of a higher cost employee.
Yes.
That clinical manager is going to cost you more
Yes.
per hour than an intake person. And
Yes.
by the time it rolls to the clinician, now you're not only getting into a cost issue, but you're getting into activities that impact their time availability to go see patients. And I think sometimes for a variety of issues, there's a lot of feelings in here. There's a lot of back and forth, like when there's tension between QA and clinicians, where clinicians think QA just sits in the office and says mean things about their work, and QA just thinks clinicians are dumb and don't pay attention, and that's why they make all these mistakes. I think we have to realize that intake to leadership to clinician is all equally valued.
Yes.
And if I'm going to look at where I'm putting my resources, I may be putting what feels like on paper more monies into this upfront. But then if I don't do this, what is it really costing me to say to the clinician, well, you didn't get this, so you need to call the doctor. You need to wait for the doctor to call you back. You need to make sure you're available to check this. I gave you the best information I had. Now you're going to spend, or you expect them to spend, a lot of time going back and forth. And my final thought before I turn it back over is sometimes I wonder if the frustration that causes a clinician to leave this setting, which always gets lumped into the documentation. It's rarely the patient care, it's the documentation. I hate it. I got to get out of it. Is it really the documentation we need them doing? Or is it the documentation they're chasing down that we could get off their plate and have them be in their sweet spot, and then have somebody in their sweet spot who knows I need a face-to-face, I need to have this. And at that very point of, I want to give you this patient, thank you very much, we need X, Y, or Z to do that.
Yes.
Because that's what I see is I think when clinicians that I talk to are just overwhelmed with the rest of it, they
Hmm.
call it documentation, but I don't think it's necessarily their own documenting. It's the phone calls, it's the back and forth, it's the you just kind of thrown to the wolves and you'll have to figure it out because this is really a clinical issue.
Yeah.
How did how did we
We're
end
like
up with the wrong
searching the
phone number?
agency.
How did
Yeah.
we end up with no contact information? How did you miss? You sent it over to me. My favorite admit of all time was a PT admit for a UTI. And you go out there and the person had a leg missing, an old stroke, and was blind in one eye. You missed the rest of it? Yes, I know the UTI is interesting, but I'm sorry. There was way more going on. And a lot of time that gets deflected as, well, you're the clinician, that's your job. Um,
And
yes, no. My job is to figure out what to do with it, but walking through the door being told this is a UTI and you have no leg, um, yeah, I think we have other issues that might make this a little bit different.
Cindy, I think the one that I my favorite in the when I had my agency was the PT only for a lobectomy of the lung, and it's like, okay, there's got to be more to this story, and I maybe we're putting the wrong descriptor name on that department, and I say we're saying intake, which means we want to intake. Would it be a better name to be the filter department or the qualifications department?
Hmm.
Because here's the thing, and I know that gets into the quality and all that stuff in the back, but if they don't make it through qualifications, then they can't go to that next step. And I think that having and I heard this once and I was repeated it a million times, and Cindy knows what I'm going to say. Home Health Addicts Core is a logistics company, and there's no way Amazon and UPS work without having all that demographic information to know where those people are located, how to bunch that delivery, how to time it, how to do all that stuff without having a great intake. And if you've ever ordered off Amazon, which everybody on this thing has,
Yeah.
then you know what you have to fill out. And they have a whole list of addresses you could choose from, payment, all those things. So do we need to take that emphasis off of intake and put it into a different direction? So, I mean, we're kind of splicing the hairs, but we're trying to get to the root of where we see a lot of long-term issues coming with these charts and on the back end. And it's interesting what you said at the beginning about coordinating things and putting them in the right form. What do we see at the rack audit level, Cindy? What do we see at TPE? We see a chart that looks like a freaking Tinker Toy set, and you send it off to the asking person, either the rack or the ADR or whatever, and they can't find things in your chart. And
Yeah,
then
it's my favorite is send 400 pages
yeah,
at,
yeah,
without any like actual organizing of it. And you think somebody who's gunning to take your money to
Yeah.
begin with is really going to carefully read 800 pages
No.
to find what they need to justify this referral. And when you talk about fundamentals, I think it speaks to issues beyond how we take a referral, but also in how are we the ones that still struggle to defend homebound status in our documentation. I think that's another indicator of when we keep seeing issues in TPE and ADRs with, homebound.
Hmm.
I think we've lost focus. I think there's a lot of, as you said at the beginning, with value-based purchasing and all of those things. I think sometimes we're chasing these big ideas, and I'm not saying they're not important, but the basics get lost, not just at intake, but what needs to be in your documentation? Why does the OASIS need to be accurate? This is not just busy work. I think we don't do the best job of necessarily explaining to all levels of the organization why, not just why, because CMS makes you. That's not a why. I think we could get better buy-in, whether it was still called intake or referral management or whatever, is to explain the value of what you do. This is
Yeah.
not just shuffling papers around. This is the beginning of their home care journey. And this is why these pieces of information are important to appropriate patient care. I think far too often that stuff gets lumped in with it's just paperwork, busy work, and CMS requirement. And so it's just misery and you have to do it. I feel like, Sherry, this is bigger than I would like people to just stop being angry at Oasis 24/7. I would like them to just stop being angry about rules all the time. Now stick to the real rules. Because
right.
I had a conversation earlier today about I'm looking for this rule. I'm looking for this rule. I can't find it. Where is it? There is no rule. Stop looking.
Yeah.
Stop trying to make the fake ones. But if we can work with those fundamentals of the actual regulation in a non-emotional, non-punitive, you can go have your moment. We have our moment now. The final rule came out on Black Friday. They're just extra mean. Go in
Yes.
the corner, stomp, have your fit, and be mad. But we got to stop being mad about the regulations all the time to the point where we cut the corner, bend the corner, forget about the corners, and then we
Well,
look at a denial reason that seems very simple. Lack of medical necessity, didn't have a face-to-face, didn't have a signed order. When you look at those denials, they're rarely something like, oh my gosh, you almost killed this patient.
Right.
There are all these basic things that just don't get done or don't get done well.
and I think about going back to basics. I come from an athletic background years and years and eons ago. And I think about when you have a baseball player, for example, hitting a baseball is one of the hardest things to do in sports. If a person goes into a slump, the very first thing they do is go back to hitting off a tee. And that's something that kids do at 4 years old. This is a basic qualification. Mm-hmm. So what we're trying to say here and what Lori's experience in helping you operationalize the plan, which is huge, you guys. And not only that, comes on site to help with operations. What is we're getting back to those basic fundamental things. So building a checkoff list for your qualifications department, which I'm now renaming intake to qualifications department. They have to literally check off, are these things there? And then your DON or your clinical supervisor can meet with the intake person once a week and say, where do we have a delay in getting this information? Because guess what? If you don't get that information in a timely manner, that's going to impact your data collection on the OASIS, right, Cindy? I mean, as we're coming to an end, talk about the compliance piece of this that we're seeing. Just about every client has a problem in this situation. And again, coming from the basics, Cindy, tell me about the OASIS thing there.
Well, no, actually, I know we have a time on this, and I want to bring back a point to Lori. Lori, what do you think? Because when you think about process and operations, there's a lot of options people have
Yep.
available to try to get help for this. What are your thoughts on kind of the one size fits all? Here is the plan for your operations. Here is the plan, and this works for you, regardless of size. You can scale it. It's perfectly scalable, whether you have 10 clinicians or 10,000 clinicians. Just do some math, and we'll tell you how many you need in intake and how many you need as clinical managers and those kinds of things. I'm curious, and I'm poking the bear. Welcome to an unfiltered. We tend to poke bears, and usually Sherry pokes me. So I'm ignoring your Oasis question, Sherry, and I'm going to poke the other bear. Just curious because in my background, I have a background in doing some operational stuff quite a while ago, but I know where my thoughts lie. I'm curious where yours do.
So, of course, in the consulting world, the majority of consultants do want to come in and do the one size fits all. Here's the plan. It's tried and true. We know this works. Me personally, I've not seen that be exceptionally effective in the long run. It might work for the short term, because doing something, right, is better than doing
Right.
nothing. But what ends up happening is that the true agency, the true habits, the actions of the people end up coming out. And so what we do at Healthcare Office Solutions, one, is we come in to understand you as an organization, as your individuals. What are your goals? What are your strengths as an agency? Do you have ICU nurses that, they used to be in ICU? Do you have cardiac cath nurses that are now on staff and you really have great outcomes around your cardiac program? What do you want to hone in on? And it's not just about like the clinical aspects, but it's about the staff that you have and understanding what they're good at, what they're not good at, and even the EMR. How is your EMR functioning for you? Have you fully optimized it? Are there elements that aren't working well for you that maybe we need to look at outsourcing or adding, another feature or, some other add-on, whether it's an AI type add-on or what have you. I mean, there's a lot of different options out here for folks, and everybody has a different pocketbook.
Mhm.
So I don't believe one size fits all, but that's why we come in and we do an operational assessment to understand you and understand your needs and your goals. And so our action plans are developed specifically for each agency as an individual with all of those things in mind. And whether, you choose healthcare office solutions or, you're just trying to look internally and see, oh, well, there's this great action plan on, out here on the internet, or Copilot says I could do this. Look at your own organization and see, do your own analysis, understand your strengths and weaknesses, and don't do it just when the final rule comes out.
Mhm.
You,
Or
you need to do it regularly.
yeah, or right now we're in budgeting season. Budgeting season
Yeah.
is a big time where people will point at all the red lights on the dash, or as our former business partner used to say, any monkey can identify a problem. So we're identifying problems like crazy in home health. We all know what's difficult and what's easy and what we're doing well and what we're not doing well. So going back to basics is a good place to start. Cindy.
Yes, your cohort is saying we've run into the end of our time. Thank you for being our guest today, Lori.
Yeah, thank you for having
We've
me.
enjoyed getting to know you and hope that you'll join us on future Unfiltered. As K&K's mantra remains, we will never ever say we know everything about everything. We like to find people that we like, know, and trust to help in different areas that we are not experts in, and we consider Lori one of those people. So thank you for joining us today, and we look forward to our next Unfiltered Productions, or when Sherry just makes me angry and hits record. So we'll see. We'll see what the next one is.
We all know those are the most fun, and we appreciate everything you guys do out there in the streets. And I just want to tell you, go back to basics, go to healthcareoffice solutions.net, right? And
Yes.
find out the tools that Lori has to help your agency and also to support another female entrepreneur. I apologize for the cacophony of dogs in the background. Somebody showed up at the house unexpectedly. Hello, home care. Okay. Thank you, everybody, and be safe out there.